Welcome, let's go to know about post-operative instruction for dental extraction. Post-extraction socket care. Remove any tooth fragments, broken fillings or calculus deposits. Trimming of sharp bony edges or projecting septa. Squeezing of the socket using thumb and index fingers. Evaluate need for suture, soft tissue laceration. Place slightly moistened gauze over socket and apply pressure. Do not dismiss the patient before adequate control of the bleeding is achieved. Clean the patient's lips and fact from any blood spots. Control of post-op hemorrhage. 1. Apply pressure to wet gauze placed directly over the socket for 1 hour. No chewing or talking, change it when needed. 2. Patient should be told it's normal to ooze for 24 hours. 3. Avoid excessive spitting. 4. Avoid vigorous rinsing. 5. Avoid drinking through straw. 6. Avoid hot drinks the day of surgery. 7. Avoid smoking the day of surgery. 8. Avoid excessive exercise. Control of post-op pain. 1. The post-op pain is usually not severe and can be managed with mild analgesics. 2. The peak pain experience occurs about 12 hours after the extraction. 3. Significant pain rarely persists longer than 2 days after surgery. 4. Prescribed pain meds. Diet. Soft and cold food on day of surgery. Use the other side. Oral hygiene. Teeth brushing. Use warm saline mouthwash the second day of surgery. 3 times/day for 5 to 7 days. Infection. Antibiotics only when required. Multiple extractions. Order of extraction. Maxilla before mandible. 1. Anesthesia becomes effective in the maxilla earlier and goes away after shorter time. 2. Calculus, part of the tooth or amalgam fragment cannot be lost in open. Mandibular socket. Posterior before anterior. 1. Better vision, since blood collects in the posterior region. 2. Better use of elevators. Hardest teeth to extract be at the end. The first molar and canine are extracted after their adjacent teeth are removed, so that advantage can be taken of earlier plane expansion and adjacent bone. Weakening. Reasons for root breakage. A. Improper application of beaks of forceps. 1. Beaks placed on enamel instead of on cementum. 2. Beaks are not parallel to long axis of tooth. B. Incorrect application of force in extraction of teeth. 1. Wrong direction. 2. Jerking the tooth, sudden, violent, application of force on one direction. 3. Use twisting motion when not indicated. 4. Pulling on a tooth. C. Using wrong type of forceps. D. Extensive caries. E. Brittleness due to non-vitality of tooth. F. Peculiar root formation. Curved, hypercementosis, divergent. G. Excessive density of surrounding bone. Condensing osteitis, osteopetrosis, isolated tooth, bridge abutment. Older patients usually have denser, more highly calcified bone that is less likely to provide adequate expansion during luxation of the tooth. Access to the field of operation. Inadequate light. Continually reposition the source of light, modify your position to avoid obstructing the light, or use a headlight. 2. Adequate access. A. Ability to open the mouth widely. B. A surgical field free of excess blood and other fluids. C. Surgically created exposure. D. Elevation and retraction of tissues away from the operative field. Surgically created exposure. The flap is a section of soft tissue that is outlined by a surgical incision, carries its own blood supply, allows surgical access to underlying tissues, can be replaced in the original position to cover and protect the site of surgery, and it can be maintained with sutures and expected to heal and promote good healing to underlying tissues. Design parameters of the soft tissue flaps. The base of the flap must be broader than the free margins. The flap must be of adequate size to allow visualization of the surgical field. Access for the insertion of required instruments. Flap to be held out of the operative field with a retractor that is resting on intact bone without tension. The length of the flap should be no more than twice the width of the base. The incisions must be made over intact bone. The flap should be designed to avoid injury to local vital structures in the field of surgery. Releasing incisions should be used only when necessary and not routinely. When vertical releasing incision is necessary, usually a single one can be used at the anterior end. It should be oblique to allow the base to be broader than the free margin. Flaps performed in edentulous ridges in the process of alveoloplasty must be trimmed. Types of flaps. Flaps may be described by shape, envelope, pyramidal, semilunar. Location, buccal, palatal. Tissues included, skin, mucosal, mucoperiosteal. Number of incision lines, 1, 2 lines, 3 lines. Number of corners, 3 corners, 4 corners. The envelope flap. The gingiva around the necks of teeth must be sharply incised before retraction. The gingival incision must extend for adequate distance mesiodistally in order to allow retraction without much tension. Advantages. 1. Less bleeding. 2. Minimum disturbance to the periosteum, which minimizes the postoperative pain, edema. 3. Better faster healing. Disadvantages. 1. Should extend for long distance mesiodistally to allow retraction without tension. 2. Disturbance of the gingival attachment. Triangular flap. 2 incision lines flap, 1 oblique incision with a gingival incision that provides for greater access, with a shorter envelope incision. Indications, for removal of small teeth or small root fragment. Rectangular flap, or trapezoidal. 3 incision lines flap, 2 oblique incisions with the gingival incision. Indications, for exposure of a large area such as removal of molars or impacted teeth, cysts or tumors. Pyramidal flaps. Advantages. Great exposure of the field. Allows discovery of any destroyed bone in the area. Allows resting of the edges on sound bone during closure. Disadvantages. Disturbance of large areas of periosteum causing postoperative pain and edema. The vertical component is difficult to close and may cause prolonged healing. Disturbance of the gingival attachment. Semilunar flaps. Indications. 1. Apicoectomy. 2. In removal of small root apex from the gingival margin. Advantages. Avoids disturbance of the gingival attachment or trauma to the papillae. Disadvantages. Limited access. Doesn't allow discovery of any destructed bone that may exist beyond the incision line of the flap. The Y incision. The pedicle flap. Pen grasp blade. The incision is made with one firm, slow stroke of a sharp blade. For the gingival incision, the blade is held in a slight angle to the teeth end. The incision is done from posterior to anterior. A sharp blade of proper size should be used. Dull blades, no clean sharp incisions. Firm, continuous stroke should be used when incising. The incision should be made with the blade held perpendicular to the epithelial surface. For the releasing incision, the tissue should be reflected apically, with the opposite hand tensing the alveolar mucosa so that the incision is made cleanly through it. Flap elevation and retraction. Woodson or number 9 Molt elevators. Broader, flat end, elevating the tissue from bone. Sharp, pointed end, reflect papillae from between teeth, loosen soft tissues via gingival sulcus. Mucosa and periosteum reflected in single layer equals mucoperiosteal flap. Elevation begins at the papilla. Reflection of soft tissue. 3 methods. 1. Prying motion, pointed end to elevate soft tissue. 2. Push stroke, broad end slid under the flap separates mucoperiosteum from bone. 3. Pull, scrape, tends to shred periosteum, if not careful. Before flap retractor held loosely in the cheek. After flap reflection retractor placed on the bone and used to retract the flap. Weeder retractor. Broad, heart-shaped. Serrated on one side, firmly engaged tongue, retract it medially. Don't position posteriorly, gagging. Thanks for watching, support us by likes and subscribes.